Let me still introduce myself. So I'm Madina. I'm one of faculty members of Molecular Pathology Division at Northwestern University. I would like to thank Thermo for inviting me to share our experience, how and when we use microarray analysis. And I hope I will handle this device. Just let me see. Aha, yes. So these are my disclosures. But main disclosure is the way how I shape this presentation. There is no background slides. The whole assumption that I'm sharing my experience with individuals like me who review and analyze cases and try to support the diagnosis, working diagnosis, final diagnosis. If you have questions about some specific interpretation of results, please feel free to stop me after. I'm happy to talk. So, and how to go back? For neuropath, that's the tumor type I picked for this presentation is well known as you. I apologize for being technologically challenged. I cannot go back. The WHO classification heavily dependent on molecular markers, which I use not only for diagnosis, yes, I mentioned I'm technologically challenged. So you can see how heavily, this is a very busy slide, but you all know that a lot of entities now have this whole desirable essential diagnostic criteria, and molecular markers are one of those. And not only diagnostic criteria, but also, as you can see this example, for astrocytoma IDH, right now, detection of IDH mutation helps to differentiate between astrocytoma IDH mutant, glioblastoma IDH wild type, and stuff like that. But another molecular marker, and that would be homozygous deletion of CDKN2A and B at 9p, would help with grading. As a result of this comprehensive molecular profiling of intracranial tumors, this is the testing menu we offer at Northwestern Medicine, which includes the most popular, very frontline test, molecular characterization by methylation array, and NGS-based test, both DNA and RNA, and of course, OncoScan. The utility of microarray analysis, we don't need to discuss it. We all know limitations and the advantages of these variable technologies. And the utility of OncoScan is to detect copy number changes, ploidy, copy neutral loss of heterozygosity, and of course, chromatopsis events. So, and technically talking about case-based scenarios is, in general, my most favorite style of presentation because that allows me to walk you through the struggles we have and various discussions we have during consensus with neuropathologists. So this case is a very good illustration of what we very frequently deal with. Yes, this is an in-house academic lab. However, neuropathology group is very well recognized and they get a lot of second opinion cases. And very often those second opinion cases have very limited information. So in this case, all we knew that the patient is 44-year-old female, that this is a brain biopsy, and the family history is uneventful, as well as her personal medical history is significant for obesity, and she also quit smoking. So that's all we know. I'm not an anatomic pathologist, so be nice, but I will try to do my best. These slides are a courtesy of a brilliant neuropathologist, and we constantly have discussions, so I'm more or less familiar with how to interpret it. So in this case, you can see this is not very diffuse tumor. There is a lot of tumor. This is spindle cell neoplasm. It's very difficult to characterize the origin of it. And what's very meaningful, there is no much mitotic activity. There is no much macrovascular proliferation. So there is a suspicion that this is glioma, but morphology is not very supportive. And glial markers, as you can see, show a very peculiar pattern. OLEC2 is absolutely negative. And GFAP shows what they discussed as entrapped immunostaining. And there is also very nice reticulin meshwork. So this is a result of methylation array clustering. And this is what we do get in approximately 10% of cases when result is no match. So methylation classification can still be helpful. In this case, for clinical use, we have very conservative and stringent way of interpreting. However, for in-house interpretation, what we did, we still looked at where the case mapped to. And it did, you can see that little star is where the case was classified. It's still in proximity to mesenchymal tumors. It's still intracranial. There is no discussion about it. However, this case was subjected for oncoscan analysis to differentiate between diffuse gliomas and neuropathology fellows still entertained the idea that it could be meningioma as well. And the reason for that was this very weird glial immunostaining, and also the fact that patient is a female, very obese, and a former smoker. So as you can see from this whole genome view plot, there is gain of 7, and there is a segmental loss of 10p. And I should mention that we already validated version 3 of copy number assessment from methylation data. And the reason I picked these first 2 cases is to illustrate the limitation of our in-house pipeline for copy number estimate from methylation data. So the top panel shows result of oncoscan. And this is version 3, the best with the highest accuracy. And the bottom version is copy number assessment from methylation data. So you can see very nice log-to ratio, and you agree with me that most of big calls are absolutely identical. However, and that's the reason why I particularly like oncoscan a lot. It helps a lot with understanding the mechanism of tumorigenesis, because you probably notice, right, immediately, the difference in pattern. Look at 10q. There is a loss of heterozygosity, right? You see the loss of heterozygous tract. So this is copy neutral loss of heterozygosity, which was not picked by copy number assessment from methylation data simply because we don't have enough SNP probes for reliable detection. So in this case, combined loss of 10p and copy neutral loss of heterozygosity of 10q allow us to conclude that at some point of tumorigenesis, there was loss of 10 with some rescue of 10q later. That's why 10q is in a copy neutral loss of heterozygosity state. So as a result of this copy number assessment, this mechanistic classification, and also molecular result, this tumor was reclassified as a glioblastoma IDH wild type, grade 4. A big difference, right, from meningioma. The second case was even less informative. No family history, no personal history, nothing. Just biopsy submitted for a second opinion. So this one is easier. We definitely see that this is diffuse glioma with a lot of mitotic activity, with a lot of macrovascular proliferation. And what's most meaningful is it's IDH strongly positive. Means what? Now for careful subclassification of classes, we need to differentiate between what? Oligodendroglioma, 1p19q coagulated IDH mutant, and astrocytoma IDH mutant, right? So that's what pathologists now most interested in. And look at the result of methylation array classification. It nicely confirmed that, yes, this tumor is IDH glioma. But for subclass, it placed it right in between. So when we discussed this case with neuropathologists, of course, being myself, I suggested, let's call it oligoastrocytoma and close the case. And the reply was, Madina, I appreciate your creativity, but let's continue. So now we need to understand whether there are two events going on, or in general, is it astrocytoma, or is it at all oligodendroglioma? Luckily, in Europath, copy number assessment is very helpful. So you see what you see. This is a plot for OncoScan, and it clearly shows that we are dealing with tetraploid genome. And I do not show the full complexity of data, but copy number profile was very significant. You can see loss of 1p and 19q with a loss of heterozygosity, meaning that that was a regional event which stays after doubling of this genome, and that's why we see now loss of heterozygosity with additional relative changes when copy number is not 4 or 8, but in between, either 5 for a gain, which happened after reduplication, or 3 for a loss. And if you compare it with our copy number assessment from methylation data, the ploidy was completely missed. And that's again due to lack of SNP information in our analysis. So you can see that, not surprisingly, this tumor was IDH mutant. We knew it from IHC, and TORT mutant. So this case was rightfully reclassified as oligodendroglioma IDH mutant, 1p19q co-deleted. Microarray also helped to grade it as a grade 3 because of homozygous loss of CDKN2A and B. So now if we move from primary CNS tumors to still intracranial tumors, and we see quite a lot of those, when the cell of origin, the tumor of origin, is not really clear. What our brilliant bioinformatics team did, they validated classification system based on methylation data, because methylation is so powerful for identification of cell of origins. First for carcinomas, and now they continue aging tumors. Now that pipeline is called tumors of unknown origin. And the case I wanted to show, where microarray analysis actually saved a lot of time and helped with diagnosis, was even more sad story. So this individual moved from a different country, and this, of course, was a second opinion case. All we knew that there was a translation involved, patient was very poor historian, and all we knew that there is a brain biopsy submitted for assessment. Biopsy was very informative. So you can see that this is not glioma, this is not primary CNS, because you see this very nice rosette formation and very solid tumor growth. And most importantly, carcinoma markers were so strongly positive. We knew that we are dealing with metastasis of carcinoma of unknown primary. As you remember, individual is 25-year-old, definitely qualifies and fit for treatment, but treatment needs to be based on the tumor of origin. It's very important. And as you can see, both analysis with CNS classes and with, here I still see, use the old name for carcinomas of unknown primary, now it's tumors of unknown primary, didn't show any match at all. So we still don't know what is the tumor type. However, on a research basis, what we did, we still looked at the proximity to the closest subclass on the carcinoma of unknown primary classification. And you can see that that case was located closest to testicular non-seminoma. So that was a good hint that indicated that copy number assessment will be helpful. And I need to mention that PGDX505 NGS panel was absolutely surprisingly negative in this case. So molecular classification would not lead us anywhere. So you can see on the left side the whole genome plot for copy number assessment. And you see this. So this is, again, tetraploid genome with a lot of complexity, but with amplification of 12p. And those who analyze a lot of germ-line tumors and as well as breast cancer tumors, they recognize this, I'm sure, amplification, which encompasses KRAS and CCND2. So that really helped to describe it as a metastasis of a testicular germ tumor for this patient. And after this reporting, neuropathology group typically puts all results together in what I like a lot. It's an integrated report with all the data in one reporting system. And then neuropathologist got back to me and said, guess what? We had a phone conversation with oncologist from the original slide. An oncologist invited patient and family back, and father remembered, yes, when his son was a baby, one of testicles was removed in the country of origin due to some possible tumor. So that, again, it confirmed the diagnosis, and it significantly helped with treatment. This is a very recent case. Unfortunately, I do not have any follow-up yet, and besides, it's an outside case. So as a result, these 3 cases hopefully convince you into something what I'm a strong believer. I'm not in favor. I really like the question yesterday asked by someone, what is an absolutely uniform test which we can just apply and get answers to all questions? I'm all for multi-model testing system, because even with nice streamlined workflow, approximately 10% of our cases are where you start fishing expedition. It's inevitable. And in this case, these 3 illustrations hopefully prove that chromosomal microarray analysis is very, very helpful. It helps to identify ploidy. It helps to identify copy number changes, and it helps with diagnosis and risk stratification. Thank you.